Hello guys, how are you? I hope you are doing fine. Back again, ophthalmology. Today we'll be discussing ophthalmology. Ophthalmology. Okay, ophthalmology. Why do we use the eyes for? We use the eyes for vision. Yes, Dr. Mo. So don't forget, in the history, I will ask psychosocial. So why do we use the eyes for? We use our eyes for vision. We use our eyes for vision. So what do you think if you have a patient who is coming to you with eye problem? Will it affect his daily activity? Yes, Dr. Mo. Will it affect if he's doing a job? Will it affect his job? Yes, Dr. Mo. If you have a vision problem, can it affect your mood? Yes, Dr. Mo. So don't ever forget, at any case of ophthalmology, to ask in history, psychosocial. After exploring the complaint, psychosocial. How is this problem affecting your daily activity? What do you do for a living? How is it affecting your job? And don't forget in management to mention DVLA. What is DVLA? Driving and Vehicle Licensing Agency. So it's an agency. If there's a problem that can affect you driving, you advise the patient. I highly advise you that you should inform the DVLA. So don't ever forget, at any case of ophthalmology in history, you will ask psychosocial. Psychosocial. What is the meaning of psychosocial? Psychosocial means that you will ask this patient, how is this problem affecting your life? How is this problem affecting your daily activity? How is this problem? What do you do for a living? And how is it affecting your job? So psychosocial in history. Anything else? Don't forget in management, don't forget to mention to the patient that he should stop driving, and he should inform DVLA. DVLA, you don't need to tell him it is the Driving and Vehicle Licensing Agency, because they all know. Inform the DVLA because they have certain rules and regulations when it comes to such and such condition. So don't forget, before we start discussing ophthalmology cases, at every case of ophthalmology, I will number one in history, psychosocial. In history, psychosocial. I will always ask psychosocial in history. What is psychosocial? I will ask about the impact of his eye problem, the impact of the eye condition on his daily activity, on his work. What do you do for a living? How is it affecting your job? And don't forget, in management, I will mention to the patient that he should inform that DVLA, and I will actually advise the patient not to drive, especially if it's affecting the acuity, the visual acuity. It's affecting his vision. Then I will talk about management. Okay, forget about this now. Let's come to the eye structure. The eye structure. If you have in the exam any case of ophthalmology, if you have a patient who's coming to you with a problem in his eyes, so what is the presenting complaint? What is the presenting complaint? The presenting complaint, P1, pain in the eye. For example, pain in his eye, okay? So pain in the eye, discharge from the eye, any complaint. So what to do when the patient is giving you a complaint about the problem in the eye? Always explore. When you explore, as you know from my structure, okay? This is like video number 28 in the course. So as you know from the medicine structure, you must explore the presenting complaint by asking an open question. Can you please tell me more? Tell me more about whichever complaint he's coming with. Then ask Socrates. What is Socrates? Pain in the eye. Site, onset, character, and everything else, and so on. And all this was explained in day one. So always explore the presenting complaint. After you explore the presenting complaint problem in the eye, After you explore it, always, 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 which eye? Left or right or both? What about the other eye? Are you able to see? Are you able to see? Is it painful? For example, if the complaint is discharged, for example, is it painful? Is it itchy? Is it watery? Any bleeding? Any discharge? Did you hurt your eye? Any trauma? What do you do for a living? Is there anything, maybe like a foreign body went inside your eyes? Do you wear contact lenses? Do you wear glasses? Do you wear glasses? So do you wear contact lenses? Do you wear glasses? Okay? So, these are the questions that I will ask in any eye problem. So any eye problem, Assalamu alaikum. How can I help you? Eye problem. Eye problem. Eye problem. So I will explore it. I will explore it. Then the eye structure. Which eye? What about the other eye? Are you able to see? Is it itchy? Is it painful? Is it watery? Any bleeding? Any discharge? By any chance you wear contact lenses? Glasses? And don't forget to bring what I have mentioned earlier about the psychosocial. About the psychosocial. Don't forget to bring the psychosocial. How is it affecting? How is it affecting your life? How is it affecting your daily activity? May I ask, what do you do for a living? What do you do for a living? And how is it affecting your job? And don't forget in the questions that I will ask in the history that ask about foreign body. Do you think that maybe something like a foreign body went inside your eyes? Okay? So this is the eye structure. So eye structure is very important. Okay? Before you start any problem to do with the eye, to have this embedded in your brain. To have this embedded in your brain. Whenever a patient is coming to you, how can I help you? How can I help you? Doctor, I'm having such a problem in my eyes. Always locate again and again and again. Which explore first the presenting complaint. As we all know from the course, this is not the first lecture. Explore the presenting complaint details and then which eye? What about the other eye? Are you able to see? Is it itchy? Is it painful? Is it watery? Any bleeding? Any discharge? By any chance you wear contact lenses? Do you have any problem with your vision? Do you wear glasses? By any chance, do you think that any foreign body, any object has went inside your eye? And don't forget, very important question that I did not mention, and maybe you are thinking about it now, fever. Do you have any fever? Do you have any fever? Do you have any fever? Fever, why? To exclude if there is any infection. Do you have any fever? Do you have any fever? So, after I finish these questions, whenever the patient gives me a presenting complaint, for example, when I ask the patient, do you have any discharge? He said, yes, I do. What to do? What to do, guys? Don't forget, if the patient gives you any presenting complaint positive, if the patient gives you any positive finding as you go down, please make sure you explore it. Stop. Tell me more. For example, if he gives you, when you ask him, any discharge by any chance? He said, yes, doctor, I have discharge from my eyes. Then explore. Explore both eyes or one eye and explore. Track. You know track, yeah? You know track from the course. Track. T-R-A-C. T for timing. The timing of the discharge. Is it in the morning? Throughout the day? Is it at night? Timing. R, relation. Is it related to anything specific? Is it related to anything specific? A, amount. How much? C is color. C is color, nature of the discharge. So always, whenever the patient gives you a presenting complaint here, you will stop and explore. And then I will go to psychosocial. How is this problem affecting your life? Daily activity. How is it affecting your life, your daily activity? And if he's doing a job, how is it affecting your job? Okay, now, after having such structure, you will follow your patient normally. Whenever he gives you something, whenever he gives you a positive finding, you will explore it, and don't forget to go back to the structure, P2, P3 maftosa. P2, P3 maftosa. So all this will come as P1. Then don't forget P2, P3 maftosa. So all this will come as a presenting complaint. But don't forget that we have P2, 2 questions. P2, 2 questions. So after we finish these questions, we know that we have P2, P3 maftosa. P2, have you had this problem before? If yes, explore. P2, 2 questions. So P2 is past test. So P1 is presenting complaint. After finishing these questions, I know that I have P2, which is past the history of presenting complaint and past the medical condition. P2 past. So P2, 2 questions. Past the history of presenting complaint, which means have you had this before? And any medical conditions. And when I ask about medical conditions, we know any medical conditions, any medical issues with your eyes. Maybe he had surgery or a medical issue in his eyes. Always ask about diabetes, because diabetes can affect the eye. Cholesterol can affect the eye. So always ask about diabetes, cholesterol problem, high blood pressure, and any previous surgery. So that's P2. So P2 is past the history of presenting complaint, which means have you had this problem before? Past the medical conditions, and by that I mean I need to mention cholesterol problem, blood sugar problem, high blood pressure problem, and previous surgeries. P3 is DASA, diet, exercise, smoking, alcohol. Don't forget, if the case is related to diabetes, if it's a diabetic retinopathy, I will ask about diet and exercise, okay? Then we have smoking and alcohol. Smoking is a must. It's very important risk factor, smoking, because it does affect the vision. And don't forget maftosa. M is for medication. Are you on any medications at all? Why? Because we know that we have some medications that can cause problems like what? Like glaucoma. Glaucoma can be caused by medication side effect. A patient could be on medication, and because of certain medications, he can have glaucoma. So don't forget to ask in maftosa, M-A-F-T-O-S-A, maftosa. By the way, I'm sure that I'm going quick through the history because that's the video number 28, 29. So I'm sure that by that you have built a rigid structure in your head, okay, in case. Okay, so maftosa, M is for medication. Are you on any medications by any chance? Is allergy, do you have any allergy to anything? If it's family history of any eye condition, okay? And don't forget, if you're suspecting an infection, so always contact the history. And OSA is occupation social, which I already brought it early. Occupation and social, how is it affecting your life? How is it affecting your daily activity? So to recap the eye structure, because I will go through the stations one by one, quick, and with the structure, you will never be lost. With Dr. Mo structure, you will never be lost. Okay? Inshallah. So, open the cubicle. Go to the patient. Confirm your full name. I'm Dr. Fatih Al-Bab, one of General Dr. Zahir. Can you please confirm your full name and date of birth? Not age. How can I help you? The patient will give me a presenting complaint. Number 1, explore in details the presenting complaint. Then after you explore the presenting complaint, anything else? Like what, doctor? Then hit him with the questions. Because you are not there to think. You are not there to look at the ceiling and start thinking of questions. No, we have Dr. Mo structures. So, which eye? What about the other eye? Are you able to see? Is it itchy? Is it painful? Any discharge? Any bleeding? Is it watery? Then, by any chance do you think you've hurt your eye? Trauma. By any chance do you think you hurt your eye? Trauma. Okay? By any chance do you think that anything went inside your eye, foreign body? Do you wear contact lenses? Do you wear glasses? Any fever? That's it. I will have my questions, which basically they've given me plenty of differentials. Then I will go to psychosocial. Psychosocial, how is this problem affecting your life, your daily activity? What do you do for a living? How is it affecting your job? Be careful, job, because the patient could be working with things that could cause foreign body in his eyes. Be careful, you must ask about job. Then I will ask psychosocial, how is it affecting your life, daily activity, your job. Then I will move on to P2, P3, Maftosa. P2, 2 questions. P2, two questions, which in brackets the past. So the first question in P2 is, have you had this before? Which I call it past history of presenting complaint. The second question in P2 is any medical conditions. Any medical conditions, like what, doctor? Like cholesterol problem, any high blood sugar, diabetes, high blood pressure, and don't forget stroke. And many strokes, because strokes can affect the eye. I will see one of the cases later on, yeah? So strokes or many strokes, and don't forget to ask about any previous surgeries. Then P3, DASA. But in P3, smoking is related to every single case. Smoking in P3. DASA, diet, exercise, smoking, alcohol. Okay? Then go to Maftosa. Are you on any medications by any chance? Because some medication side effect can cause problem like glaucoma. Any allergy to anything? Because some allergy can cause itching and redness. Any family history of any eye condition. And TOSA, T for travel or contact. If you're suspecting infection, if you're suspecting anything contagious. And then O for occupation, S for social, which you have already mentioned before. Now, I will start discussing every and each station quickly with the management. All right? So, first station is cataract. Cataract. You are an FY2 doctor in the medicine department. Emma Wilson, 70 years old, has some concerns. She went to her GP last week, who advised her not to drive. So she's coming now. She went to the GP last week, and the GP advised her not to drive. And now she's coming to you, okay? Okay. Now, again, I will follow the same structure. Same structure, okay? So, I can see in the question one line, which is, she has been to the GP and he advised her not to drive. So, please, would you like to know why did she go to the GP from the first place? Yes, Dr. Mo. So that will be my approach. I can see from my note, Mrs. Wilson, Mrs. Emma, Mrs. whatever, that you have been to the GP last week. May I ask why did you go? Then she will give you a complaint. Then she'll give you a presenting complaint. What did he advise you to do? Then she will give you. So you are basically asking 20 or 30 seconds about the previous visit that she had. Why did she go? What did the GP advise? Then you will start the station by the complaint. So why did you go? She will give you a complaint. So what to do? Explore the complaint, and then ask these questions. And then psychosocial, and then P2, P3, Maftosa. So now, when I discuss a case one by one, I will give you the positives. What do you mean, Dr. Mo, the positives? The positives that the patient will have and will direct you toward the cataract. So in every station, I will give you the stem. Then I will give you the positive finding. Why, Dr. Mo, only positive finding? Because you know the structure. P1, all these questions, psychosocial, P2, P3, Maftosa. So once I give you the positive, once you know the positive, you know where you're going. So, cataract. The positive will be, number one, doctor, my eyesight is blurry. So, blurry eyesight. Okay? Doctor, the light's too bright or glaring. So, the lights are too bright. So, the eyesight is blurry. I have blurred vision. And the lights are too bright or glaring. So, the lights are too bright or glaring. The eyesight is blurred. She will tell you it's harder to see on low light. So she has a problem. When there is light, when she looks at the light, she can see the light different. The eye vision is blurry. Okay? And All the colors for hair looks faded. All the colors looks faded. So the red is not red, it's faded. Yellow, so the colors are faded. Okay, we will know now why, because it's basically the problem is in the lens. Okay, sometimes there is fluid accumulation in the lens. The problem is in the lens. That's why she can see things fading. Okay, colors fading. Okay, and she feels as if the lenses in her eyes are dirty and it needs cleaning. Okay, and sometimes she feels that when she's wearing her glasses, she tells you, I wear glasses and I feel that, doctor, I always need to clean my glasses. So always she's having something hazy. So cataract is a presentation from a patient who feels that something is hazy. Something is hazy. She could be wearing glasses and as if there is something in the glasses that the glasses needs cleaning. I told you, as simple as problem in that lens. As simple as if in her lens, she feels that it needs cleaning. The glasses, something shade on the glasses. The glasses are not clean. The glasses are dirty. When she looks at the light, blurry vision. When she looks at the colors are faded, cataract. But obviously, I will follow this structure. Okay? So I'll ask her about pain, discharge, bleeding, trauma, everything. Okay? Now, I will finish the history. As I told you, these are the positive in the history, but I will follow the same structure. Then, examination. You will verbalize examination. You will verbalize that I will check the observation and visual acuity, visual field, normal. Okay? Then, you will move to management. In management, and in diagnosis. So, diagnosis and management. Diagnosis, the problem is in the lens. So, the problem here is in the lens. The lenses in the eyes. Okay? Management, guys. Number one, I know the 7 steps. You know the 7 steps. But I will give you the bullet point in management and you follow my 7 steps in day 1. So always go back to day 1. So management, I will refer to eye specialist. I will be talking to my senior. Investigations, I will do all bloods including diabetes. So I need to check blood sugar. So all bloods, routine bloods including blood sugar. Okay? Then step 4, symptomatic and lifestyle. Always talk about lifestyle. This patient, smoking, alcohol. This patient diet, because it is to do with diabetes. So diabetes is a factor. Okay, so symptomatic and lifestyle. Always talk about the patient lifestyle because it's important. Lifestyle like diet, exercise, smoking, alcohol. Okay, and now according to the condition. According to the condition means that sometimes cataract gets worse over time, which eventually will need surgery. So later, the further management, depending on the condition. So my management as an FY2, as a Mickey Mouse doctor, is as simple as senior, referral to eye specialist, routine investigations including blood sugar, cholesterol, etc. Okay, advice about lifestyle. But further management will depend on the condition. What do you mean, Dr. Mo? If the cataract is not that bad, if I will tell her, depending on the condition, the further management will be. So, if the problem, if the vision is not really bad, so what we're going to do is glasses. We're going to give her stronger glasses. So, she will have stronger glasses, okay? And she will have more brighter. So, she'll have brighter reading light. So, when she's reading, she'll have a brighter reading light, reading light, and she will have glasses, stronger glasses, okay? But if it's too bad, she can have surgery. And some patients surgery is the only way for treatment, okay? Now, sometimes they give steroids. Sometimes they do give steroids. Sometimes one of the causes is steroid. So always ask about medication. So one of the possible causes can be steroid side effect. So now, safety netting, driving, and DVLA. So safety netting, driving, and DVLA. So now to recap cataract. Cataract, I said to you, problem is in the lens of the eye. As if it's dirty lenses. Clear? That's between me and you now. Forget about it. How can I help you? Doctor? Blurry vision. Doctor, when I look at the bright light, the light, it looks more brighter to me. Doctor, When I'm reading, it's not good, it's not clear. When I look at the colors are faded, all of this. Doctor, sometimes when I wear my glasses, I feel that the lenses are dirty. I feel that as if there is something on the lenses. I feel that my glasses needs cleaning because it's like as if it's a dirty lens in the eye, okay? I told you, always ask about lifestyle, DESA, because DESA is a factor. This patient could be diabetic. Diabetes is a cause, is a factor. Steroid side effect is a factor. So always ask about steroid as medication side effect. On medications, are you on any medications? Then go to management. When I manage, in management, I said to you, senior, referral to eye specialist, investigations, routine blood mainly, blood sugar, cholesterol, and then I will go to symptomatic and lifestyle. Lifestyle DESA is important because it's a factor, so always talk about lifestyle. If there is something like to do with smoking, the patient diet is not good, it's a factor. And always talk about, we have three situations. We have some situations where that's as a further management, yeah? As a further management. We could give you stronger glasses, okay? Stronger power lenses, stronger glasses, or we can even help you with bright light while you are reading. However, some cases can be too bad, or sometimes the case gets worse to the level that you will need surgery, and that will be the only treatment is surgery. Now, talk about DVLA. They should inform the DVLA because of the vision problem. Next is age-related macular degeneration. Age-related, from the name, age-related macular degeneration. The stationary RFY to doctor in the medicine department, Sandra Green, 87 years old, came with vision problem. So now I will follow the same structure. The same structure. How can I help you? P1, explore. Which eye? What about the other eye? Are you able to see? Is it itchy? Is it painful? Any bleeding? Any discharge? Trauma? Foreign body? Lenses? Glasses? Okay? If they're wearing any contact lenses or if they're wearing any glasses. Then psychosocial, then P2, P3 maphtosis. Now, in this case, what are the positive findings? What will the patient give you as a positive finding? Again, he will give you blurred or distorted area in your vision. So he will tell you, doctor, some areas of my vision are blurry or distorted. So that is the first presenting complaint. Second presenting complaint, seeing straight lines as wavy. So this patient can see the straight lines wavy. So seeing the straight lines wavy. 3, colors seems less bright. Like what? Like the cataract. So the colors seem less bright than they used to. The object seems smaller. So as if it's age-related macular degeneration, as if the macula is getting small. The macula is shrinking. So when the macula is shrinking, think about it. Think about it in a village way. The macula is shrinking. So everything is shrinking. So he sees everything smaller than normal. The size of things smaller than normal. Okay? He sees the straight lines wavy. He also see the colors less bright. The colors fading. So faded color, object looks smaller than normal. Straight lines, he can see it wavy. Blurred vision again. And sometimes seeing things that's not there. Sometimes they feel that they are hallucinating. Sometimes they tell the doctor, we see sometimes things that's not actually there. As if it's visual hallucination. Okay, but there is no hallucination here. But it's all because the macula is degenerating. The macula is shrinking because of the age. Age-related macular degeneration. So from the name, always remember, you don't need to memorize plenty of stuff in Lab 2. From the name, age-related. So age is a factor. Related macular A. Macular what? Macular degeneration. The macula is getting small, so everything is getting small. The colors are less bright. The lines are, because it's shrinking, so the lines are wavy, not straight. Okay, now, history, finish, follow the structure, ask about everything as we mentioned, P2, P3 maphtosa, normal. Then I will move on to management. In management, again, 7 steps. I'll talk to my senior. We need to refer you to eye specialist. Be careful because here, they sometimes refer them, the referral, I'm not going to say urgent, but I'm going to say the referral within days. So this patient will be referred within days, okay? Within days. All right, so step three, investigations, which is we're gonna do the normal investigation. Again, we're gonna do check the bloods, routine investigation, blood for blood sugar, cholesterol level, same. And then we're gonna do treatment. Step 4 is symptomatic and lifestyle. Very important lifestyle management, exactly like cataracts, because the acute, the age-related macular degeneration is often linked to unhealthy lifestyle. So please, DASA is important. So DASA not only is important in cataract, but also is important in age-related macular degeneration. So diet, exercise, smoking, alcohol. All right, and sometimes we consider talking to them about the fact that they need to take supplements. Okay, so be careful, because it is similar to cataract management. Referral, both of them, senior, both of them, investigation, both of them are the same. Both of them related to DASA. So both of them, if there's a problem in DASA, you must advise. However, in cataract, we said the difference here. So up until DASA, the same. But in cataract, we said it could be managed only with stronger glasses and bright light. Cataract could be managed surgically if it's getting worse, if it's not improving. Okay, here management, the symptomatic step, we have two types. We have dry age-related macular degeneration and wet age-related macular degeneration. So we have two types. Do I need to know which type? No, I'm not a specialist. Is it my job to know which type? No, I will be discussing with the patient. Well, we're gonna talk to my senior. We'll refer you to eye specialist. Okay, he will do further management. But for now, we'll check some blood, routine blood sugar, cholesterol. Some lifestyle modification needs to be addressed. Talk to him about lifestyle modification. I said to him, when we refer you to ophthalmologist, the management will be depending. We have two types. We have dry age-related macular degeneration. We have wet age-related macular. So two types of age-related macular degeneration. If it's dry, would you like me to tell you what we're gonna do? Yes, doctor. In these cases, usually there is no treatment, but what we do is visual aids that will help you to have better quality of life. So visual aids. However, if it is wet, age-related macular degeneration, in these cases, we have two options of management, which is eye injection of some medication. So we'll inject your eyes with some medications. And the other option is light treatment, which we call it photodynamic therapy, to stop your eye problem from getting worse. So if it's dry, nothing, no treatment, just visual aid. If it's wet, two options. Either we inject your eyes with some medication, or we use what we call it photodynamic therapy, which is light treatment. So treating using light, like laser, same principles as laser. Photodynamic therapy or light treatment. Okay, with the eye injection, they said that that's for you. You don't need to tell him what will you inject, what will the specialist inject. But I'm telling you, the injection will be given directly into the eyes. It will stop the eyes from getting worse. Usually it's given every 2 to 3 months. Every 2 to 3 months, and it has some side effect like bleeding from the eye and sometimes red eye, and the eye will be irritation. So that's the injection. The light treatment is basically light will be shined into the back of your eye that will destroy the abnormal blood vessels. Okay, that is causing the wet acute macular degeneration. Side effect, temporary vision problem. Anyway, so these are the specialist management. So specialist treatment 2. So I have the acute macular, dry or wet. Dry, no treatment, visual aid. Wet, in this, either you will inject something in the eye or you will use laser treatment or light treatment or photodynamic. Okay, and both you can talk about it. If you say, well, I will inject it will be injected directly into the eyes, it has some side effect. red eye, bleeding from the eye, irritation, and doctor, how often? If this will happen, every 2 to 3 months. Okay, that's for the injection. For the light, it's basically beam will be directed into the back of your eye. Why? Why? To damage any or to destroy any abnormal blood vessels. Okay, finally, after the further management is the safety netting. Safety netting, safety netting, safety netting again, DVLA, DVLA, DVLA. So they should inform the DVLA. And be careful because there is some support I can talk about later on. Well, there are some supports for patients with acute macular degeneration. Like what, doctor? Like we have some clinics called low vision clinics where we can refer you to, and these clinics will advise you about how to deal with the difficulties that you have because of your condition. Again, we can refer you also to a certain type of training called eccentric viewing training. Again, it will help you, it will teach you some techniques that will help you on, or that will advise you on how to keep the remaining vision. So all these things, and there's something called macular society, some support to groups. So that's the management of acute macular degeneration. So acute macular degeneration management, as simple as number 1, senior, number 2, referral to eye specialist, number 3, investigation routine, blood cholesterol, number 4, symptomatic and lifestyle. Lifestyle is DESA, symptomatic depending on the type, which is further management depending on the type. It could be dry, it could be wet. Dry, nothing but visual aid. Wet is either injection in the eye or laser. And be careful because this is further management. Be careful because that's not the way management will go. If you go back to day 1 in the structure, it's all about two-way conversation. It's all about ping pong, things going back and forth. So it's the way you talk to the patient. So please make sure you talk nicely. Make sure you always ask the patient, would you like me to tell you more about this? Do you want to hear about this? So always talk in a way that it's two-way conversation. Be careful. The next case is diabetic retinopathy. Diabetic retinopathy, and from the name of it, diabetes. Do you know the acute macular degeneration? Shrinkage of the macula. When I say shrinkage, so the straight line will be wavy. When I say shrinkage, so that means that the things will be smaller. When I say shrinkage, that means that the color will be faded. So, diabetic retinopathy, straightforward. A case of problem in the eye due to diabetes. That's one presentation. Another presentation, they could bring you a patient that he doesn't know, or she doesn't know she is diabetic, but she is presenting as a first presentation of the eye problem. What do you mean, Dr. Mo? We have two scenarios, okay? One of them, when you ask the patient any medical condition, the patient will say, yes, I'm diabetic. That's straightforward. Another scenario, if you ask the patient any medical condition, he or she will say, no medical condition, doctor. But when you ask them about the lifestyle, they have bad lifestyle, unhealthy lifestyle that can take you toward diabetes. And sometimes they give you symptoms of diabetes, like, doctor, we've lost a bit of weight, doctor, we go to the bathroom more often than normal, which means that they don't know yet they have diabetes, but they have diabetes, which means that the first presentation to you is with the complication. So be careful, yeah? Nothing will change in management, but one of them you will say diabetic clinic, the other one will say blood sugar to check if you are diabetic or not. That's it. So you are an FY2 doctor in the GB clinic. David Smith, 50 years old, was referred by the optometrist. The optometrist, guys, in UK, the optometrist is the technician that you go to for glasses. That's it. That's optometrist. He's not a doctor. He's not ophthalmologist. So in this case, 50 years old was referred by the optometrist who was concerned for early diabetic retinopathy, which means that this patient has gone to someone for glasses, and when they were examining his eyes, they said, we are concerned about diabetic retinopathy, so they referred him to you. So always the start, always the approach. I can confirm my identity. I am Dr. Fatih Helba, one of the general doctors here. Can you confirm your full name and date of birth? I can see from my note that I have been referred by the optometrist. Can you please tell me why did you go to the optometrist from the first place? Then he will give you a complaint, then explore it in details. When you explore it in details, after exploring the complaint in details, P1, anything else? No. Then go to that, is it itchy, is it painful, any bleeding, any discharge, any trauma, foreign body, occupation, and ask about fever, and then you will go psychosocial, then P2, P3 maftosa. And in this case, because it's diabetes, so the patient will give you DESA, gone. DESA, everything is bad. And the patient DESA, diet, exercise, smoking, alcohol will be no good. And the patient will give you a complaint of, in the past medical history, P2. When you ask him any medical condition, he will say, doctor, I'm diabetic. If he said no, I don't, so from the lifestyle, you will know it's early diabetic complication. So in this case, what are the symptoms? The symptoms, the positive finding. Gradually worsening vision. Doctor, my vision is getting worse, worse and worse. Okay? Doctor, he will tell you, doctor, sometimes I have what we call it floaters. What is floaters? Floaters, doctor, things that is floating in my visual vision. So, he will complain of a vision that's getting worse. And you need to explore what do you mean by getting worse. And you need to explore the timing, the period in which the vision is getting worse. This patient will tell you about floaters in his visual field, things that is floating in the visual field, the floaters, so shapes that is floating in my visual field. This patient will say that sometimes I have some eye pain or redness. That's it, but mainly floaters, worsening vision, and they can tell you about the eye pain or redness. You will follow the structure, no problem, and then you will go to management. When you verbalize examination, you will only verbalize. You will verbalize what? You will verbalize visual acuity. Visual acuity, very important. Visual acuity, all right? Then you will come to management, visual acuity, and the back of your eyes, fundoscope. So in this case, you need to do fundoscope, which means that you're gonna look at the back of the eye and the visual acuity. Now, management of diabetic retinopathy, forget about this. I said to you, it is what? It is diabetes. It is diabetes. So this patient, you need to talk about DESA. That's your job. Your job is investigations, blood sugar, hemoglobin A1C. Your job is DESA, because DESA will be not good. Diet, exercise, smoking, alcohol. Your job will be so blood investigation, blood sugar, cholesterol, hemoglobin A1C, DESA management, and your job will be referral to ophthalmologist. The ophthalmologist will deal with that. So, management. Number 1, talk to senior. Number 2, refer to eye specialist. Number 3, will do some investigations like what? Routine blood sugar, cholesterol, hemoglobin A1C. Number 4, symptomatic and lifestyle. Lifestyle is advising about diet, exercise, smoking, alcohol. Again, advising about diet. You should advise about eating healthy food and smoking. Okay, you should advise him, you should tell him that he should stop smoking, because smoking does affect the vision and they will make it get worse. Exercise, he should exercise regularly. Okay, and alcohol to decrease it to the normal limits, which is 14 units. Then the further management, like any eye condition. Then further management. The further management here is, we have options. If it's in the early stage, so early stage diabetic retinopathy, nothing but lifestyle, with the lifestyle modification and the controlling the diabetes, making it under control, that will prevent the vision from getting worse. So lifestyle, that's, you're gonna say to him. Further, depending on the ophthalmologist. Many options we can have here. Some of them, if there is early changes, if there is early diabetic changes, early, with the lifestyle modification and the medication and controlling your diabetes, will prevent this from getting worse. That's it. Done. No surgery, nothing. Okay? What about the advanced stages, doctor? What about the advanced? So, if the ophthalmologist check your eyes and find that it's advanced, then there are many ways of treatment, like what? Like laser treatment, or eye injections. They inject your eyes with certain medication, or surgery. So 3 options: laser, injection, surgery. If you go back to the age-related macular degeneration, the wet, not the dry, the wet, it was the same. It was laser or injections. Here is the same. Laser or injection or surgery. And finally is safety netting, DVLA and advise him about the importance of regular screening of his vision. So regular checking for the vision, and you can even say or refer to the diabetic clinic. Okay, so that is diabetic retinopathy. And please, you don't need to talk about things in laser. You don't need to talk about details of surgery. You don't need to talk about details of injections. Okay, but all what you need to know that diabetic retinopathy is abnormal growth of blood vessels in the back of your eyes. Abnormal growth of blood vessels in the back of your eyes. Sometimes it ruptures, and it is basically the diabetes that is causing the blood vessel to be weak and dilated. So weak and dilated. So that's diabetic retinopathy. So diabetic retinopathy changes is in the back of the eyes, the retina. The blood vessels in your eyes gets thin, weak, fragile, gets dilated, and sometimes it ruptures, leading to abnormal blood vessels. That's it, as simple as that. Blood vessels, because of the blood sugar, getting weak, fragile, dilated. And sometimes it ruptures, leading to abnormal growth of blood vessels in the back of your eyes. Okay? That's the provisional diagnosis. Then glaucoma. Glaucoma, you need to know, guys, you need to know glaucoma is basically very common case. The presentation is painful red eye. Be careful. Glaucoma equal what? Painful red eye. So the eye will be painful, the eye will be red. End of story. So glaucoma, painful red eye. Again, painful red eye. So how can I help you? Doctor, severe eye pain. Severe eye pain and redness. So painful red eye. So I will follow the structure. How can I help you? Doctor, I have severe pain in my eye. Painful. Socrates. S for site, O for onset, C character, R radiation, and A aggravating relieving factor, A and R, and then timing, and then severity, and then anything else. So you will ask the patient, Socrates, in details about the pain. Which eye? What about the other eye? Is it both eyes? Are you able to see? Onset, how did it start? So Socrates, S site, O onset, how did it start? All of a sudden, gradual. Character, what type of pain is it? Radiation, does it go anywhere else in your body? Or is it just the eye? Anything that makes it worse? Anything that makes it better? And you can say to him, what were you doing just before you developed this pain? What were you doing just before you developed this pain? Because there are some risk factors. Maybe he was in the cinema. And in the cinema, it's dark light, and then the screen, shining screen. So in the cinema, maybe he wasn't the doctor, optometrist, or whatever, and he was giving eye drops. So what were you doing, or what happened just before you had this problem, just before you had this pain? Very important, okay? Then T timing, sense swim, severity on a scale from 1 to 10. How would you grade your pain? And that's it, Socrates. After that, as normal, guys, pain in the eye, pain. Don't forget to ask about trauma, foreign body. Did you hurt your eye? So don't forget. So we said, which eye? What about the other eye? Are you able to see? Is it itchy? Is it watery? Any bleeding? Any discharge? Ask about contact lenses. Ask about fever. Ask about if he's already wearing glasses. Okay? And do you think that foreign body went inside your eyes? What do you do for a living? Do you think that something went inside your eyes? And in these cases, you will see the patient in the cubicle having sunglasses. So when you open the cubicle, you will see the patient in the room with sunglasses. So that's a hint. The patient will be in the room with sunglasses. Okay. So positive finding, painful red, painful red, painful red, painful red. That's it. Okay. Then you'll go to P2. Have you had any problem in the eye before? Any medical conditions like diabetes, like cholesterol? Then P3, DESA, because it's an emergency, forget about it. Only ask smoking. So it's an emergency. Emergency cases, you don't ask DESA. Emergency cases, you don't ask DESA. You can only ask about smoking. And then M is for medication. Are you on any medications? It's very important. Very, 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 very important. So I've mentioned now, very important, because some medication side effects like amitriptyline causes glaucoma. So, are you on any medications? The patient will say, yes, doctor. What medication? I'm using amitriptyline. What for? For depression, doctor. How is your depression? Depression is okay. So now, one of the medication side effect, like amitriptyline, can cause glaucoma. Be careful. So glaucoma can be caused by what? Medication side effect, like amitriptyline. So amitriptyline is a medication that they use it for depression and sometimes for pain as well, nerve pain, neuropathic pain, and side effect is glaucoma. So be careful. So in this case, the patient will give you presenting complaint pain for red eye. In this case, the patient will give you that he is or she is on medication and the medication side effect can cause it. What is the medication? Amitriptyline. Okay, that's it. So the symptoms are, the positive findings are intense eye pain. The patient can have red eye, so intense eye pain, red eye, sometimes nausea or vomiting, headache, tenderness around the eye, and sometimes he can complain of seeing rings around light. Okay, colored halos around light. So that's glaucoma. So glaucoma, painful eye, red eye, sometimes because the pressure is high in the eye, because acute closed angle glaucoma, the pressure will be high inside the eye, so that can lead to headache, that can lead to nausea and vomiting. Okay, now examination, you will verbalize that the pressure in the eyes needs to be examined by the specialist, not you. So who will measure the pressure in the eye, inside the eye? The specialist. So the pressure inside the eyes needs to be measured by the specialist. So we will measure the pressure inside your eyes. Okay, now acute closed angle glaucoma, when you give provisional diagnosis, you will say basically it is a condition of the eye, which is really caused by decrease in the absorption of the fluids in your eye. Our eyes are two compartments, the fluid accumulates there is decrease in the absorption of this fluid that leads to increase in the pressure of the eyes. That's why you are complaining of severe pain, intense pain, headache, vomiting, nausea. Okay, management, how to manage it. Don't forget that in the acute closed angle glaucoma, I was discussing two things. I said be careful. You must ask the patient about what he or she were doing just before this problem. What he or she were doing just before this problem. And be careful because you need to ask about medication side effect, yeah? So, management, it's an emergency. So, management, refer to ophthalmology department immediately. Don't forget, so refer to ophthalmology department immediately. Or if you are in the ophthalmology department, admit. So if the question said ophthalmology, admit. If it says hospital, refer to ophthalmology immediately. Don't forget to mention the word immediate. Referral. Number 2, senior. Number 3, investigations. What are the investigations? These investigations and these examinations will be done by specialists. They will measure the pressure inside your eyes. And they will examine your eye using a special light and a magnifier called a slit lamp. Okay, so be careful because you need to mention this under the specialist. So I will be talking to my senior. Why? Because you will need to be referred immediately to ophthalmology department immediately, yeah, which will further examine you. They will check your eyes, they will examine the pressure inside your eyes, they will measure the pressure inside your eyes, and also they will use a slit lamp, which is a slit lamp. They will use a slit lamp, which is a special light and magnifier called slit lamp. Okay, now we need to give the patient a medication. So this patient will be given topical medication, topical eye drops, topical medication. So medication, eye drops, and they will be giving a medication through his veins. So we'll be giving you medications through your veins as well as eye drops. We know the eye drops, timolol, and we know the acetazolamide IV. So we'll be giving you medication through your veins immediately, which is called the acetazolamide. You don't need to tell him. And we'll be giving you other medications like timolol, and pilocarpine. So timolol, pilocarpine, acetazolamide. Great, great. Immediate referral, further examination, and I will say to him that can be followed by laser treatment. Laser treatment, laser treatment. Why? To stop the fluids from accumulating inside your eyes. That's it. So that can be followed by laser treatment to stop the fluids from accumulating inside your eyes, because the original cause was accumulation of fluid. Now the unaffected eye is usually also treated. Why? To prevent anything from happening. Okay, safety netting again, DVLA, and safety netting is always review with a specialist. And as I told you, in this case, if the patient is on medication, amitriptyline, review medication. If the patient is on amitriptyline, review medication. If the patient is on amitriptyline, review medication. That's the acute closed angle glaucoma. Okay. Finally, the last case, subconjunctival hemorrhage. Subconjunctival hemorrhage. Before I talk about subconjunctival hemorrhage, it's basically a simple case of red eye. That's it. Red eye. So what is the presenting complaint, Dr. Mo? Red eye. The patient is coming, all his main concerns are red eye. My eye is red, doctor, very red. So red eye. Let me discuss with you in a village way, subconjunctival hemorrhage. The only complaint, red eye. The eye is very red. Doctor, I woke up in the morning with my eye very red. One eye. Okay. Anything else? No. Painful, itchy, bleeding, discharge, any itchy, contact lenses, glasses, foreign body, trauma, nothing. Everything is negative. Usually he tells you, I woke up in the morning with my eye red. Nothing else. Nothing coming out of the eye. No pain, no nothing at all, just red eye. When I ask about everything else is negative. All right, so red eye and everything else is negative. All right, okay. Psychosocial, you don't ask psychosocial in acute cases like glaucoma. You don't ask psychosocial in a case that's just appeared in the morning. Okay, P2, B3 maftosa, Dr. Mo. P2, B3 maftosa. Yes, P2, have you had this before? No. P3, any medical conditions? You must ask any medical conditions. Yes, no. And then smoking is a factor. You need to ask about smoking. And MAF maftosa. MAF. However, in this case, what will be the positive finding as a risk factor? Okay, the patient will come with red eye. That's it. Red eye. Woke up in the morning with red eye. Nothing else. Everything else is negative. So the patient will come to you with red eye. Everything else is negative. So forget about everything. The patient will come with red eye. Everything else is negative. Be careful. But you will have to have risk factors. Why is the patient having red eye? Why is he having red eye? The patient having red eye because of increase in the pressure inside his body. So the patient will be having increased the pressure inside his body. Like what, doctor? Like coughing, sneezing, constipation, difficulty in passing urine, and it could be that the patient is having a bleeding disorder or blood thinner. So again, can it have causes? Yes. One of the most common risk factors for subconjunctival hemorrhage, which is basically red eye, only red eye factors. What are the factors? Anything that makes the pressure increase, like coughing, sneezing, constipation, difficulty in passing urine. Anything that increases the pressure in the body can lead to rupture of the blood vessels in the eye. That's it. So constipation, start from up, going down, coughing, sneezing, constipation, difficulty in passing urine, also high blood pressure, diabetes is a factor because it is thin blood vessel, as we know from diabetic retinopathy. High blood pressure, thin blood vessel, bleeding disorder, blood thinners. That's it. So in these cases, you must ask about the risk factors. So it's only red eye, nothing else. So you will take history, but when you take history, always ask about coughing, sneezing, constipation, difficulty in passing urine, bleeding disorder, blood thinner, and high cholesterol, diabetes, and that's it. Management is nothing. I will give him artificial tears. Nothing. Management is nothing but artificial tears. I will measure the blood pressure. It's very important to measure in examination. In examination, verbalize that you will examine the eye. In examination, the examiner will give you a picture of red eye. Verbalize that you will measure the blood pressure. That's it. So examine the eye, measure blood pressure. Then in management, nothing at all but artificial tears. And advice about the risk factor: coughing, sneezing, constipation, difficulty in passing urine, and that's it. And safety net. Okay? So, you are an FY2 doctor in the A&E, Hunt, 78 years old, male, presented to the hospital complaining of red eye. That's it. How can I help you? Doctor, I have red eye. I woke up in the morning with my eye red. Explore the red eye. Since when? How did it start? Anything that makes it worse? Anything that makes it better? All of a sudden, yes, it started, doctor, all of a sudden. I woke up in the morning with it. Apart from the red eye, anything else? No, doctor. Go with the history. Go with the history. Go with the history. Anything else? Like, is it itchy? No. Painful? No. Discharge? No. Bleeding? No. Foreign body? No. Trauma? No. Fever? No. Everything else is no. Have you had this before? No. Any medical condition, he may give you blood pressure or diabetes. What are the factors in this case? The risk factor: the patient will be diabetic and or high blood pressure and or bleeding disorder and or blood thinner. 4 things: diabetic, high blood pressure, bleeding disorder, blood thinner, because it's all about bleeding in the eye. It is bleeding in the eye, not bleeding that you can see, but rupture of the blood vessels. It is rupture of the very tiny capillaries in the eye. So there is no actual bleeding, but it's red. Okay? So I will ask the risk factors: high blood pressure, cholesterol, diabetes, bleeding disorder, blood thinner. Where can I ask this? In B2, because I have P2, past history of present complaint, and past medical condition. Then I will go to P3 DESA, ask about smoking. Okay? And here you can ask about, in the smoking, you can ask about other risk factors like what? Cough, sneezing, constipation, difficulty in passing urine. Very important. These are the risk factors. Okay? Now, you will finish the history. Examination. Verbalize that you will examine the eye. You will be given a picture. Verbalize that you will check the blood pressure because it's a factor. Then, provisional diagnosis: it's a bleeding in the eye. Small capillaries, small blood vessels in the eye may be ruptured, leading to this picture. And the reason is, give him the reason. The reason is high blood pressure. The reason is high blood sugar. The reason is, so give him the reason. Okay? How to manage, guys? As I told you guys, management as simple as nothing. I will talk to my senior because we need to run some investigations. Like what, doctor? Like what, doctor? Full blood count, bleeding profile, clotting profile, INR. Okay? Okay? And we may take a swab from the eye to exclude infection. We may take a swab from the eye to exclude infection. Okay? You can say, we may also refer you to ophthalmologist to measure the blood, to measure the pressure inside your eye, and that's it. But what is the treatment here? What is the treatment here? Okay, we know that I will talk to my senior. We know that I will check the blood for the clotting profile because it's a bleeding in the eye. It is bleeding in the eye. So we'll check the clotting profile, full blood count. We'll check the bleeding profile and the INR. But what else? What else in management? In management, if everything came back negative, there is no treatment required. The only thing is, we can give you artificial tears. Artificial tears that can be used 4 times. 4 times. Artificial tear. That's the only thing. Nothing else. And I will advise him, don't touch it, don't rub it, don't use any painkiller, don't wear any contact lenses. So, don't touch, don't rub, don't use painkiller, don't use contact lenses. Okay? Safety netting, if it persists, come right away to us. If it persists, come right away to us. What if Dr. Momi found that the patient has high blood pressure and it's uncontrolled and this is the cause? And when I verbalized the examination, they said high blood pressure. You can refer to cardiologist or you can refer him to his GP, or you can refer him to cardiologist for monitoring of blood pressure. Okay? Alright, so management. Senior, Investigations what? Bleeding profile, clotting profile, full blood count, and this patient might have further examination like what? Tonometry, which is the measurement of the pressure inside the eye, and this patient might take a swab to exclude infection. These are the investigations. So investigations, swab to exclude infection, clotting profile. And you can even measure here the blood sugar, because it could be diabetes, cholesterol, blood sugar and cholesterol. Then, is there anything you can do? No. If everything came negative, the only thing is artificial tears, 4 times a day. That's it. Anything else, doctor? No. But make sure you don't rub your eye, you don't play in your eye, you don't put any contact lenses. Safety netting, if it gets worse, come back to us, let us know. Okay? Thank you very much. Ophthalmology is finished, and see you in the next video, inshallah. Bye bye.